Thank you again for everyone for joining tonight. Let me catch my breath here for a second. My name is Kevin Jambi, Marketing Manager for Inova's Sports Medicine Orthopedics Department. I'll be monitoring tonight's question and answer section in chat, assisting with the interactive portion of today's program, and responding to any non-medical questions. Before we get started, I'd like to go over a few housekeeping items so you'll know how to participate in today's event. First, all attendees are muted and your video is off. Please note that the webinar is being recorded and will be sent to everyone who is registered in a few days. We will also be sharing this on social media and on our website. You'll have the opportunity to ask questions of today's speakers in two ways. So first is to type your questions into the question and answer box, which can be done at any time during the presentation. And I'll read those to our speaker during the question and answer session at the end of the presentation. If you're interested in a question already posted with someone else, you can click a thumbs up icon, and that will move it up in the order to be asked. The other option is, should you want to ask a question directly following the prepared remarks, you can click on the raise hand icon on your toolbar. That will alert us that you want to speak so we can unmute you. Just a reminder, this is an informative talk only, not intended to replace your own physician's advice. In order to protect your privacy and ensure you receive a thoughtful response, we suggest that you discuss the specifics of your medical condition. I'm sorry, y'all. 1 second. Okay. Sorry, I lost my way. Just 1 second, everybody. In order to protect your privacy, ensure you receive a thoughtful response, we suggest that you discuss specifics with your medical condition and symptoms with your personal physician or contact our speakers privately after this program ends. You can find contact information at inova.org, and I'll provide that later. Before I introduce our speaker, I want to introduce two nurse navigators joining us tonight. Sarah Price, nurse navigator at Inova Alexandria, and Ashley Maliarakis, a nurse navigator at Inova Loudoun. Sarah and Ashley, go ahead and please introduce yourselves.
Hi, yes, I'm Sarah Price, and I'm the nurse navigator at Inova Alexandria Hospital. We have a pretty robust spine program there, as we do at all 5 of the hospitals. And as navigators, we do our best to, what it sounds like, navigate the patient through the surgical process from beginning to end. That starts by providing pre-op education to patients once they're scheduled for surgery. And then we see patients in the hospital to make sure things are going well afterwards. And then we're available all throughout the recovery journey as well. We work closely with the surgeons and with the wider teams at the hospital just to make sure that we are following best practices and going above and beyond for our patients. So it's great to be here tonight.
Well, Sarah said that perfectly. I'm Ashley Maliarakis. I'm the spine navigator at Inova Loudoun. I've started my career in surgical nursing, so I've always kind of known the world and have been deeply rooted in spine for the past decade. It's a joy to be by the patient's side throughout the whole journey. Like Sarah was saying, we're the right-hand man of the surgeon, as well as the patient, as well as the nurses, and all the different disciplines that are involved in the patient's care to get them successfully from point A, preoperative, getting scheduled, all the way through until the very end, until they leave us and go to their follow-up. So pleasure to be here tonight and happy to answer any questions with you guys.
Thanks, Sarah and Ashley. So obviously our main speaker tonight is Dr. Siddiqui. And I'll do a quick little intro of him, and then he will lead tonight's presentation. He's an orthopedic surgeon, board certified, and specializing in minimally invasive spine surgery. He's been practicing in Northern Virginia since 2005, and recently joined us in 2024. And has clinic hours across 3 different clinics across Northern Virginia, so that's a real asset. He's probably as close to you as you can imagine with those sites. His clinical areas of interest include minimally invasive spine surgery, and over the last 20 years, he's had multiple publications, abstracts, presentations, and chapters written on spinal surgery. He's on the editorial review or for Current Concepts Orthopedics, a peer-reviewed journal, and he's an active member of the Society of Minimally Invasive Spine Surgery. He's been in the Washingtonian Magazine's Top Doctors. He's been in Northern Virginia Magazine's Top Doctors. He's a great resource for Inova, and just recently, actually, he published a really phenomenal article for everyone to read on Northern Virginia Magazine. I'll throw that link on here now. Dr. Siddiqui, thank you so much for spending time with us tonight, and I'll let you take it from here.
Yeah, thanks, Kevin. Thanks, Sarah and Ashley. Thanks, everyone who is coming out tonight, this evening, to go through one of my passions. As a spine surgeon for many decades, finishing medical school back at Vanderbilt in 1999, I've been on this journey of trying to find solutions that are, less invasive when it comes to back and neck pain. And Kevin's gone over a little bit of this about myself. I really have been committed to the area and been here for greater than 20 years, and I've been very excited to be part of the Inova team. And when we talk about team, it really is a team at Inova, and we have, in addition to myself, we have over a dozen spinal surgeons, both in orthopedic and neurosurgery, who are excellent. And as a team, we work and are committed to quality. We have, peer review monthly meetings. We try to do the best for our patients. We try to do the best in the community, and we try to stay on top of the newest technology that's out there. And one of the technologies that we have that is really in its infancy is minimally invasive surgery or endoscopic surgery, and that's one of the things that I'll talk about. Other things that I also focus on is percutaneous pedicle fixation, fusions and hardware, and also robotic surgery. But I brought in a few models, which I don't know if you can see on the screens, but surgery in all of its essence is evolving to smaller and smaller incisions. So there are traditional surgeries where we take the spine, we make like 6-7 inch incisions, and the enterprise of doing the operation, the large cuts, leaves patients with some collateral damage. You can do a big operation, have the surgery, but then you're left with these big incisions, and there's issues with that as well down the line. So one of the solutions which we at Inova have been working on is how can we do a lot of this less invasively, and what are the technologies that are out there. So one of them is endoscopic surgery, where instead of taking a scalpel 6-7 centimeters and a small less than 2 to 4 millimeter incision, and going down through a 7 to 10 millimeter tube and trying to do the same work that we would do with a traditional surgery, with the idea that, hey, let's minimize any trauma to the muscles, the fascia, the tendons, and really do what we're supposed to do, which is to open up the nerves, free the joints, remove any stenosis or arthritis, and cause as less pain and less collateral damage as we can. And on the picture on the right, you can see where we have traditional surgery, where you have to make a large incision, you have to open it, whereas with an endoscopic, you're using little tubes, and you're creating a videoscope through these little 7 to 10 millimeter in diameter tubes, and doing the same type of work, with the idea that it's going to be less pain, quicker recovery, and safer outcomes, because there's be less blood loss, less risk of infection. And this is a good slide of what I was showing earlier. On the left, you have retractors that are going in, stretching the muscles, opening the muscles to the point that they can have necrosis or pressure on them. Whereas on the right, you have alternatives where you have smaller tubular tools that are kind of making almost like small little puncture wounds into the body, and then attaching a video scope. And this is something that Arthrex has been doing for many years in the sports medicine world, with knee surgeries, shoulder surgeries. You probably have friends and family who have had arthroscopic shoulder procedures or arthroscopic meniscus surgeries on the knees. And we are using that same technology now and evolving it into the field of spine surgery. One of the newer technologies, which is made by Arthrex and which has allowed it to be used in the spine, is that now their cameras are ultra high definition, 8K, 8,000 K of data, which, around the spine, around the nerves, you want to have the best visualization at all possible. And the Arthrex technology, which is called the Synergy Vision, allows for that. In fact, with the camera, you can automatically change the rotation of the angle just by the digital computer algorithms, so you can see different parts of the nerves. You can look up, down with the same tube without moving anything. Also, they've perfected the technology where they can put a high definition camera on the tip of a needle, so that way they can put that in places into the spine that are much, much safer than traditional tubes that were used for shoulder or knee surgeries. And why that's important in the spine is that when you have, this is a model of a spine in here, at the front and the back, and the yellow are the nerves. So when you have instruments moving around with the nerves, the smaller it is, the less it's going to push and irritate the nerves and cause less irritation, less chance of nerve damage, because there's not as much real estate in the spine or the spinal cord compared to the anatomy of a knee or a shoulder. Some of this I've already talked about, but a lot of these procedures, I have patients going back to work within 7 to 14 days. The endoscopic procedures are exclusively done in an outpatient setting, so patients can have these done at the surgery center, which I'll go into in a little bit future, about talking about the Woodburn Surgery Center and some of the technology that we have there. Less pain, quicker recovery. The fact that you're moving faster and there's less chance of blood clots, less chance of wound dehiscence, less chance of other complications associated with larger surgeries. In this slide, I'd like to just talk about a few of the minimally invasive procedures. And in order to do that, I'd like to first talk about some of the pathology that we see. So the most common that we see is what's called a herniated disc, or in layman's term, a bulging disc, or layman's term sometimes called a slip disc. And I have a model here where you can see this is the center is the disc. And if the disc extravasates out, it causes a herniation here. And that disc does two things. It causes mechanical irritation on the nerve because the disc is touching the nerve. Think of getting an eyelash or a piece of dust in your eye. It tears it up. Secondly, the gel itself is very acidic and can cause an inflammatory response. So think of getting shampoo in your eye. It creates a chemical irritation. So one of the goals with endoscopic discectomy is to go ahead and try to remove that red fragment with the least amount of trauma through a small tubular incision, and really in essence, in layman's terms, kind of free and remove that fragment to relieve that symptoms of sciatica or in layman's terms, shooting pain down into the legs. Second thing that we can do with surgery of the spine is if someone has what's called spinal stenosis, which is the calcium that builds up in the tunnels when the nerves come through. Very common as we age. The prevalence of that in someone who's 65 and older is greater than 90%. And I give the analogy of calcium buildup of spinal stenosis, kind of like a sailboat in the ocean for 65 or 70 years. You get barnacles and calcium buildup on the side of a ship. The same thing happens here. So the stenosis and that calcium that builds up causes symptoms of back pain and sciatica. And one of the procedures with minimally invasive endoscopic surgery is to go in and remove the calcium and remove that buildup. And that's done kind of in this section here. The third area of pain is what's called the facets. Okay, so in the front you have the discs and they provide your flexion and extension, but you also have these little joints in the back that provide kind of the rotation and the flexibility from side to side. Sometimes you may hear that pop or click when you rotate. And the facets are where you over years can lose that cushion on the joint that connects one facet to the other. So one of the options, instead of doing the traditional spinal fusion where you put screws and rods to kind of immobilize that facet and stop movement, one of the alternatives is to block the nerve that gives innervation or pain feeling to that joint. And that's the medial branch, okay? The theory there and the idea there is that if you may not stop arthritis, but if you can block the nerve and if you can transect it, patients can have somewhere between 3 to 7 years of pain relief without having to go through the spinal fusion procedure and then have to deal with the side effects of that. The most common of those side effects when you fuse the spine is that it does put pressure on the level above or below. So the procedure, and there's a picture here showing where using an endoscopic tool, you cauterize the medial branch of the nerve that innervates that joint, and that can alleviate the arthritic pain of the back, like I said, anywhere from 3 to 7 years. And during that time, I tell patients if you do your homework, which is stretching, exercise, weight reduction, that procedure may provide enough relief that you may not have to go through a bigger operation down the line. And that's where, when we talk about outcomes and what to expect, we want surgery, at least for minimally invasive spine surgery, to be something that helps patients return to a full and active lifestyle, knowing full well that arthritis, is always prevalent as we get older. I tell patients, Uncle Arthur will be there forever. But if you can alleviate the pain, help them do things with mobility, exercise, with minimal dissection, minimal invasiveness, it may be enough to allow them to function. And that brings us to Inova and where we're doing this. We're doing this at the Inova Woodburn Surgery Center. I'm so excited about this. I was talking offline with Kevin how, this center is the latest and greatest. It is, it is what I dreamed of 20 years ago, having an area or a center where you have, state-of-the-art robotic knee surgeries, robotic hip surgeries, but also now minimally invasive spine surgeries. And it's done right across the Fairfax campus, Fairfax Hospital campus, and it's fully, licensed, takes all the Inova Medicare approved insurances, and is a great place for this technology. And in fact, in the whole Inova campuses, it's the only Arthrex Technology Center that we have as of 2025. One of the other things about the Woodburn Surgery Center is that it's one of the few surgery centers that there's a physical therapist who will come in and see you before you go. We set that up and we arrange that where after you've had your procedure, you can go ahead and see a therapist, make sure you're moving well, make sure you're navigating steps, walking before we send you out the same day. That's always been one of the concerns with patients. Hey, if I have an outpatient surgery, how do I know I'm not going to just be, pushed out the door? And I can assure you at Inova and the Woodburn Surgery Center and with all the ancillary people who are involved, including the therapists, the nurses, you're going to get just the same level of care as you would in the inpatient setting, and also have all the advantages of a less invasive outcome. I want to thank Kevin for putting this together and thank all of you for joining. If there are any questions that you guys have, please don't hesitate to let me know. Thank you.
Dr. Siddiqui, let's start with the first one. How long does the medial branch nerve transection last?
The medial branch transection can last anywhere from 3 to 7 years, sometimes longer. Prior to this technology, a lot of these patients were getting what is called a radiofrequency ablation by pain management doctors. The radiofrequency ablation is just a fancy word for taking a needle and heating the tip like the tip of a microwave and cauterizing that branch. So the RFA ablation procedure has been done for many, many decades. The problem is that a certain percentage of time that nerve, the medial branch, is in the bone, or what we call interosseous, so that procedure doesn't work. So when you do it under direct visualization and you go in with the endoscope, you more effectively transect that nerve. And in terms of pain relief, it can be anywhere from 3 to 7 years. And why that large number, 3 to 7 years? It's because patients have to do the homework. You got to continue to work on stretching, exercise, weight reduction, all those things to help make sure the arthritic pain doesn't come back.
So here's a question on somebody who's had a surgery, maybe in the 90s, 2000s, for herniated disc or any type of surgery. That pain was taken care of, but now they're dealing with, a different pain in the spine or lower back, especially across the waist, maybe even. What's their next steps?
Okay, so when we backtrack, the procedure to remove a disc herniation is what's called a decompression or a laminectomy or a laminotomy, which is to remove this bone, this white bone right here, and remove that and create a window, and then remove the red part where the disc is. When you remove the red part, that helps the leg pain and the sciatica, but sometimes when you remove the bone in the back, it can kind of destabilize the bone and the joint segment. And if that happens, that can create, facet or joint pain. So the next step in someone like that would be to check appropriate imaging to make sure that there's no signs of any instability. And then if not, then you would do a diagnostic lidocaine injection into that facet to see if that alleviates the back pain. And if that does, then they would be a candidate for the endoscopic procedure.
Well, thank you for that. And I'll make sure I follow up with Barry about that one. Another question. This is an interesting one. I don't know. How many levels of the spine can you treat in one surgery/section, if you will?
Endoscopically, approximately 3 to 4. You can do 3 to 4 levels. Very routinely. There are 5. So let's step back for a second. There are 3 parts to the spine: the cervical, the thoracic, and the lumbar, okay? And we're going to talk right now about the lumbar. There are 5 levels: L1, L2, L3, L4, L5, okay? And usually with this, we do 3 to 4 at a time. And just to educate everyone, when we use these numbers, L1, L2, L3, L4, L5, they're for the nerves that are coming out from the center of the spine, and they go and they spread and they innervate different parts of the body. So the L1, think of that as kind of the upper hip area. L2 is kind of the side and mid thigh. L3, we're getting towards the knee. L4 to the shin, and L5 to the foot. The analogy I give patients is, you think of your spine as I-66, and then you have all the different, you have Fairfax County Parkway, Reston Parkway, Route 28, Sudley Road. So all these nerves are going into different areas. And in one setting with the lumbar, the most you would do would be 3 to 4 of these in one setting. That's a good question.
Another one, can you also treat, oh boy, spondylosis and retrolithiasis?
Okay, so we can blame the medical anatomist of putting everything in terms of Latin and Greek. Okay, so the word spondylosis is a Greek term for back arthritic changes. So the term spondylosis is a term that we use very commonly as a catch-all phrase for arthritic conditions. So number one, to answer your question, yes, spondylosis, the arthritic part of that is what we would treat with these type of endoscopic procedures. Now, retrolithiasis, let's just break that into 2 parts because they're both words that are Greek and Latin. Listhesis means slip, okay? Means there's movement. Retro means backwards. Antero is another form, which is going forward, okay? Now, as human beings age, there is some mild retro or anterior listhesis, and I would say that if it's a stable and it's not moving, meaning that's not loose, you could be a candidate for these procedures. However, if that slip listhesis is moving, and the way to tell that would be special x-rays with bending forward and backward, then those patients would more likely then need something like this to stabilize that. But to review, spondylosis is a catch-all term for arthritic conditions that could be treated. And then listhesis, whether it's retro meaning backwards or anterior meaning forward, is something that is a sign of kind of movement or instability. And a lot of those patients first, before even surgery, we recommend exercise, core strengthening, stabilize the multifidus muscles, the transversalis muscles, things like Pilates, yoga, maintaining that core is very important.
Can you give a quick your thoughts on if someone's asking about stem cells? Is there anything you can do with that?
Okay, so the stem cell literature is, kind of in its infancy. There are some studies, most recently out of Stanford University, where it has been used for tendinitis and epicondylitis. There's been some very well designed studies for tennis elbow and lower leg tendinitis. The jury is still out about spine. We have 2 or 3 physicians in the orthopedic sports medicine division that focus on not only stem cells, but PRP, which is platelet-rich plasma, and those type of procedures. If patients are interested with, they can make a consultation with MSK and discuss that.
What are your thoughts about steroid injections for pain management?
So steroid injections, historically, when we go back and when I was discussing earlier the pathophysiology of a disc herniation, and I was talking about, remember, there's mechanical pressure when the jelly hits the nerve, and then secondly, my analogy of when there's the chemical irritation of like almost the gel leaking out and causing inflammation, kind of like getting shampoo or aftershave in your eye. The steroid injections are very beneficial for calming that inflammatory response down. The steroids themselves neutralize that chemical irritation. And then that combined with homework, including physiotherapy, strengthening, and core exercises, are very good, have a very good outcome, okay? However, if in addition to just chemical irritation, there's a huge or large disc or red part, then the efficacy of the injections are much less. And the test to tell if they're going to help or not is the MRI, the magnetic resonance test, where you go through a tube and you check, and it shows all the soft tissue, the discs, the nerves.
Excellent answer. Thank you for addressing all that. Can you describe in more detail a microdiscectomy? How long is the surgery and recovery time?
Yeah, so when we step back and we say discectomy, is just the term that we use to remove the gelatinous red part here, okay? Traditionally, it was done through the laminectomy, which is a large incision. The microdiscectomy now is done using a microscope and smaller incisions. Those incisions, depending on the retractors that are used, if they use tubular retractors, that incision can be 22 millimeters or 24 millimeters. So you're going in with a tube, the microscope, you're not removing the entire white part, you're just making a small window so that you can trim and remove that disc. So that's what's a microdiscectomy, sometimes also known as a micro decompression, okay? Now, that procedure takes anywhere from 60 minutes to 90 minutes. It's an outpatient procedure. And the recovery time, and if we're assuming it's just a one-level microdiscectomy, a recovery time for that is about 4 to 6 weeks. And what does that mean? The first 1 to 2 days, you convalesce, rest at home. Day number 3, you start some gentle therapy, walking. And then day number 2 weeks, you would then have more intensive therapy with the idea by approximately 4 to 6 weeks, you would go back to full activities with bending, twisting, and motion.
Thanks. And we're going to continue on with some tough questions. And I'm glad you're here, Dr. Siddiqui, because I cannot answer any of these. What is the limitation of what you can't do with minimally invasive procedures? Specifically, if you have like a symmetric disc bulge with bilateral facet arthrosis and severe spinal stenosis, is that a candidate or not?
Yeah, so what are the limits of minimally endoscopic spine surgery? I would say that depending on if someone has, if we go back to the lecture in terms of you've got a disc issue, you've got the stenosis, which is the calcium buildup, and on top of that, you've got the facet arthrosis. I would say that if you have 2 of the 3, the endoscopic is probably more advantageous. But if you've got all 3, which if someone's got a symmetric disc bulge, severe spinal stenosis, and the facet arthropathy, then the endoscopic may not be the best solution for you. And that's one of the advantages of being part of the Inova team that I'm at, is that I have surgeons who are very passionate about certain different procedures within spine. I have some of my colleagues and friends who are very passionate about tumors and tumors of the spine, and they're great spine surgeons at Alexandria that I send to. And there's some colleagues of mine who are really passionate about open traditional surgery or scoliosis surgery, and I would send them to Loudoun Hospital or Fairfax Hospital. So rest assured that each patient, we go through a thoughtful discussion about which procedures are efficacious and which ones aren't going to be that effective. And just because we have new technology like minimally invasive surgery, it doesn't mean that, you know, everyone needs it or everyone fits in it. But I can reassure you that we would at least navigate and put you with the right providers in our system if that's the case. But to answer your particular question on that patient who has a disc, facet, and arthritis, they're probably not the best ideal candidate. But having said that, you only know until you examine them, and then if it has to go to a more traditional, we'll help that at Inova.
Sure. I think there's two questions on spinal canal stenosis. Is that a potential for minimally invasive surgery?
So yes, going back, spinal canal stenosis is basically the analogy I was using when there's calcium or barnacles that build up on the tube of the tunnel where the nerves are going through, which is different than the disc part. It's more of just the encroachment of the calcium and buildup, and that you can minimally invasively remove the calcium without having to do traditional fusion.
Okay. All right, I'm going to keep the questions rolling. We've got a lot, but I think we can handle it easily here. Someone had spinal surgery in 2023, C3 is 7, having trouble keeping their neck up and it freezes when the head down. It shows that it fused. Are you accepting new patients? Do you have an office in Ashburn? That's a great lead-in.
So number one, yes, we see patients at the Ashburn Healthplex on Mondays. Happy to see them there, and then my neurosurgical colleagues see them. Dr. Wynn and Dr. Chandela see patients at Loudoun Hospital. So very happy to help facilitate a consultation. Going back so that everyone who's on the call, C3 to C7 means that when you think of your spine, remember there's lumbar, thoracic, and cervical. And the cervical has 7 levels: C1, C2, C3, C4, C5, C6, C7. And unfortunately, in 2025, with patients always bending, twisting on their phones, it's very common to wear out the lower discs, 3, 4, 5, 6, 7. So if someone's had a fusion at multiple levels, which this patient has, it does put pressure on discs above and below, and could definitely cause some weakness into the muscles into the other area. And having what's called a fusion, meaning going back to what I was talking about with the instrument hardware, does not necessarily mean they can't still have some weakness in those muscles. So I would say that those patients who've had that procedure for the neck area, there should be alternatives, especially with someone who had surgery so recently in 2023, which has only been 2 years. So I would, to answer the question, I think there would be options, and we're happy with Inova. We have excellent doctors in Loudoun County. Either myself or my neurosurgical partner colleagues would be happy to entertain and give a second opinion.
Do you recommend trigger injections?
So let's backtrack. What is a trigger injection, and what does it facilitate, and what does it do? So when someone has a purely muscular issue, i.e., Dr. Siddiqui, I was walking my dog and he torqued me, and I pulled my muscles in my trapezius, or I pulled my muscles in my lower multifidus, lower back and gluteus area, and I've done therapy and I've done exercises, and my x-rays and imaging show no structural, issues like a disc. Then the idea is, to kickstart the healing of that muscle. Sometimes an injection in that muscle that is triggering or inflaming can help accelerate the healing of that muscle. So where I use trigger point injections are patients who have muscular issues or muscle injuries, and who after the injection go back and do their homework, which is stretching, exercise, and working on that muscle that's triggering.
length. Okay, let me get to this next one. We're whittling down the list, Dr. Siddiqui. So this is you're really churning through them. I was told that a disc replacement for L5S1 has a very low rate of success and would not be an option. Are there other options outside of disc replacement and fusion for degenerative disc, even experimental?
Excellent question. So let's backtrack. Okay, so when we talk about degenerative disc disease, we're talking about pain that is coming exclusively from the disc itself. Okay, so this is not due to a disc rupture or a disc herniation. It's innately the degeneration of the disc area itself, and we know from science that the innervation of the disc itself is around the edges in the lining of the annulus. So one of the options outside of replacing the entire disc or fusing the entire disc is to do what's called an intracept procedure. I'll say it out loud and spell it INTRACEPT. And that is also a minimally invasive procedure. In fact, we're doing one at Woodburn with Dr. Lamb, who is at Fair Oaks, who's an interventional pain specialist. And the idea there is that you put in an electrode that innervates the sinovertebral nerve, which is the nerve that innervates the lining of the disc. And you kind of neutralize that area, similar to what I was talking about, the medial branch, which is for the facet. But for that, they can neutralize that, and that can alleviate that pain. And again, the time frame is anywhere from 3 to 7 years because it is a degenerative process. So that procedure is called intracept, INTRACEPT. And you can definitely see Dr. Lamb at the he's part of the Inova Interventional Pain Group, or Dr. Chiata at Loudon would be those are two very good doctors to have a consultation about that procedure.
We got another one. We got 3 more from the webinar chat, and I'm going to finish off the question and answer ones. How do you minimize scarring when you have something like a right L5S1 vasectomy, spinal fusion, etc.? I'm not going to go through all of that one there, but I'm assuming you get the gist.
Yeah. So when you talk, unfortunately, all open or traditional surgeries, by the very nature of removing the lamina, removing the bone, can cause some scarring or inflammation that can occur. Now, how do you minimize that? We use different type of tools. Now, endoscopy is one type of tool where you use an endoscope, where you're causing less trauma and less tissue damage. But there are other ways that you can do that intraoperatively, and there are other tools. You've probably heard of bovine cauterization. There are other tools, like one of them is called an aquamantis, which is to kind of cauterize and kind of cause hemostasis in a less muscle trauma way. There are also things that you can place on top of the nerves after you've finished the procedure to minimize scarring as well. But scarring is the challenge in all of any surgeon's existence. But those are some of the technologies that at Inova we have as well. And, we take great care on hemostasis, and, we have a whole ERAS protocol which is team dependent, evidence-based. The use of tranexamic acid is one of those things that we help with hemostasis. So I would assure you that at Inova, we really focus on the cutting edge and latest technology that can help minimize, maybe not obviate scar tissue, but minimize any scar tissue.
At what point would you recommend the facet nerve surgery when the pain management doctor has recommended a steroid injection in both sides to see if that helps? I think that's a common question of when do you make that leap to surgery?
Yeah, so that's excellent. You always do one or two, depending on the insurances, of those facet injections for two reasons. One is they will give you a good idea. They will give you a good idea of how much pain relief you would expect if you underwent the procedure. That's number one. And number two, there are patients who get one or two injections, combine that with physical therapy, exercise, and weight reduction, and they're okay. They're happy, and they never need the medial transection. So there's a cohort of patients who go through with that. So I would say I would recommend either one or two injections before even considering doing the medial branch transection. One or two plus homework.
And can you do minimally invasive spine surgery for ADR, namely a C6-7 cervical disc replacement?
So if someone has had a cervical disc replacement, which let's go back to my model, it's removing the disc in the front, they're still going to have some movement of that joint in the back. So wherever there's movement, there's going to be motion. Wherever there's motion, there can be pain. So in those cases, you would first do a diagnostic injection of that facet. If it relieved pain, then they would be a candidate for the endoscopic.
And apologies if you've already answered this one. What is your take on fact joint ablation injection?
The injection is a precursor to allow diagnostic relief, meaning that say, hey, that's my pain generator, and then two, the medication that's injected to help with inflammation will help promote some pain relief, so patients can get active and move and work on the homework, the exercise, the Pilates, the strengthening. So my thoughts on that are it doesn't hurt to try doing one of those prior to going the route of endoscopic surgery.
All right, we're really getting down to the nitty gritty. I believe we've only got about two left. I was told that a disc replacement for L5 S1 has a very low rate of success. I think you might even ask. Nope, we answered that one already. I actually think, specifically, do you do cervical spine stenosis surgery based on patient symptom or based on MRI findings? Sometimes patients have mild symptom even with severe stenosis on an MRI.
Yeah, so that's an excellent question, and that's been Dr. Scott Bowden out of Emory University did a study that 40% of patients can have stenosis on imaging but be asymptomatic. So I would opine, having practiced for over 2 decades, 20 plus years, I go by symptoms and not by imaging. I have patients in my practice currently with severe spinal stenosis that I've been following for years, that are neurologically stable, that are doing fine. And there's a lot of recent literature out of the Japanese studies showing that patients with spinal stenosis long-term do not have a higher predilection of having any impending paralysis or impending nerve damage if they're asymptomatic. So to answer that specific question, I treat the patient, and I watch the patient, and I've watched patients for years or decades, irrespective of what the imaging shows.
Well, that's excellent. And that takes us to our last question. So I want to actually give you a minute, Dr. Siddiqui, if you wanted to put any contact information in the chat, a direct way individuals might be able to book with you. Obviously, I've put in the our sports medicine orthopedics call center, and they know that you're hosting this AT tonight, and they're expecting some calls tomorrow. That number is at 571-472-6464. I believe Sarah or Ashley has put in the spine program number, but if not, we can also do that as well, and that can get to Dr. Siddiqui as well. I do want to thank you for your time, Dr. Siddiqui. It was absolutely phenomenal. You answered all the questions. Again, I also put the Dr. Siddiqui's webpage and his Nova magazine article. It's really a quick read. I suggest everyone dive into that. Also tonight, everyone will be receiving a short 5-question about a minute long survey following the presentation. And you'll get a follow-up email within the next about a week with a link of the video to today's recording in case you were looking for any specific answers. Again, you didn't quite hear them. I know Dr. Siddiqui answered a few people on individuals they should reach out to, so that would be in the recording. You can just skip right to those answers. Dr. Siddiqui, if there was anything you wanted to leave us with before adjourning tonight's session.
I just wanted to thank everyone for coming. I wanted to thank Sarah, Ashley, and Kevin. And I'd like to say that, the beauty of Inova is we're a team, and, whether you can come in and see me or see some of our excellent, great doctors in any of our other hospitals, you can talk with Ashley. Loudon has Dr. Wynn, Dr. Chandela. Sarah can put you in touch with Dr. Fanous, Dr. Mo. Really, I am just one person in a whole large group that's dedicated to helping our patients, irrespective of whether I do the surgery or somebody else does the surgery. You just want good outcomes for our community and want to use the latest and best technology and see if you're a candidate or not. Thank you very much, everybody.
Absolutely. Thanks, Dr. Siddiqui. I think that's a wonderful way to put our seamless care. And thank you, everyone, for joining tonight. Again, you will receive a recording of this in less than about a week. And if you need any guidance, I will put my email in the chat. If you need anything in particular, if you need a direct route to Dr. Siddiqui, if you want to learn more, if there was something you were missing or a question you didn't get to ask, feel free to email me. I do not mind routing. So again, thank you so much to everyone, and I appreciate your time, Dr. Siddiqui.
Thanks, everybody.